Sup, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And my name's Mark.
So, Mark, what is on the agenda for today?
All right, Kane. Today we're going to be talking about what we have termed activity reconditioning. And what we mean by that is patients who they don't have a directional preference, they haven't responded symptomatically to motor control or loading strategies, and it's essentially that group of people who they said they need something different, right? So, Kane, I'm going to throw it back to you. Why don't you give us, if you want to give us a little bit of a definition, or give us some examples of patients who would fall into this category?
Yeah, so activity reconditioning for me is like pretty much what you said. Patients who have inconsistent symptom presentations. You haven't found anything that really hits their deficits and creates a significant or a lasting change. It feels like maybe their symptoms are getting a little bit better, maybe a little worse. You can't really tell. And I feel like those patients, it's really important to work with them in regards to just getting their general levels of activity up, just exposing them to more and more of their provocative motions. Maybe it's that, they have trouble getting up and down from a chair. It tends to bother them. They have trouble walking, or it's a patient who's had low back pain that just has not responded in the manner that you might expect it to typically respond. So these patients, I am just getting them up and moving for the most part, seeing what they can tolerate, gauging their symptom response, and then gradually kind of progressing them from there. I think that it's just like this concept of, and this is what we normally do in PT usually as well too, which is like you're trying to progress your patients. You're trying to increase the complexity, the difficulty of the exercises, either through more volume, more loading, just like what we talked about in the last episode. But when you're able to capture that and show patients, oh, this is what you're able to do now, whereas before you couldn't do it without it being super provocative. Now they're starting to understand, okay, maybe I can do more and more and more. And it starts to shift their perspective on their symptoms and how they're responding. What do you typically, or how do you typically use this principle for your own practice, Mark?
Yeah. So, right, these patients, there is still a mechanical, there's still an orthopedic component, right? So you mentioned the inconsistency as being a characteristic of this patient population. I think there's also like a subgroup that we could fit in where maybe their response is, or their symptomatic response is consistent, but it is consistently unresponsive, right? So
True.
Unresponsive in that you're not able to make a symptomatic change with movement or with our interventions, right? So in the group of people where they have an inconsistent response, to me it's more so something like, okay, we have our baseline level of function, we have their baseline limitations, and we're going to do our interventions, we're going to gradually progress them in a different way than we would progress someone who, has a positive symptomatic response and that it's reduced. But we're going to progress them over time. We're going to make sure they're improving from a functional standpoint. And that's kind of how, that's how we address it, right? It's just because it's inconsistent or because we're not noticing a change within the session, a quick noticeable change. It doesn't mean that there isn't a progression scheme, right? So more exposure, more load, more activity over time. That's essentially what it looks like. And because the response can be variable, right? The intervention and the dosage is going to be variable as well.
Yeah, I think that monitoring that is just so important. And I think that the fact that Mark captured that last part where it's like getting someone who has a consistent and like their symptoms are consistently non-responsive, I think is what you said, right? I think that is just those patients can be very, very tough to work with. because
Hmm.
we've tried everything. We've tried all these things. It's like we're doing the things that we're supposed to be doing. Why are they not getting any better? And I mean, to be quite honest with you, I have no idea why exactly they are presenting in that manner, why their symptoms aren't responding how we would typically expect them to. I think
Right.
there's a lot of factors that can go into it, but we still need to be able to address these issues, you know. And I think that that's where showing people that they are able to do these things is really empowering for them, but also it just helps to shape their a change in their perspective. Instead of it being like, oh, every time I do this it hurts, now it becomes, oh, I can do this now and it hurts less, or I can do more without it causing any flare ups. So that's usually where being able to actually have slow and steady progressions for people, it really does make a big difference. But I think like one of the things that I've noticed is for people who are responding symptomatically, I'm progressing them fast. You know, like it is like,
Right. Right.
it's not something where I'm like, oh, okay, we need to do it super systematically. Okay, you can only go up one increment each
Hmm.
time. Like I made sure that I bumped up your volume so I can't push your load today. Like I don't really think like that for people who are symptomatic. If they are responding well and I can get their symptoms to change, I'm gonna push that envelope a little bit more. But for these patients, I am a lot more systematic where it's like, okay, maybe I need to push them to do an extra 1 or 2 reps today. Maybe they can't do that. Maybe we need to regress them a little bit depending on how they're feeling. So it's really interesting to see like the change in how you kind of manage your patient based on their response to load and to the different interventions that you're giving as well.
Yeah. Right. So like I mentioned earlier, like there's a symptomatic response, maybe just not a lasting positive one, but like you had just said, like because there is a response, we need to gauge it. We need to understand what's having an effect or what's causing the response, right? What's having an effect on that response. So even if it's something where they in the previous session, they did, you're in the current session, you add 1 or 2 reps, you add a set, right? You're going to educate them. Okay, let's see what happens during. Let's see how you feel the rest of the day, and then let's see how you feel between now and when you come in for your next session. All that kind of information you can gather to get a better idea of how you're going to progress this patient over time.
Yeah, it seems so silly
Hmm.
because it's like for these patients, I just never put a whole lot of emphasis on this, and or like at least never really considered utilizing this as part of my practice where it's just like general exercise. I used to just think, why would I just generally exercise someone? You can just go to the
Hmm.
gym, right? Like it
Yeah.
just doesn't make sense. Like to me, I want to fix things. I want to make sure that there's a problem and that I address the deficit. Boom, done. Moving on. But for these patients, it's definitely different. I've grown a deeper appreciation for the way that I have to change my practice for these people. Where now I don't think of it as, oh, they're not responding, they must be faking it, they must
Yeah.
be a chronic pain patient, they must be like in their head about it. And sometimes earlier in my career I would just be like, okay, we just need to figure out what that missing deficit is. And the longer that I tried to chase my tail, the more frustrated I got.
Yeah. Yeah.
And so that's when I realized that, oh, even as I continue chasing all these deficits and doing everything, they are gradually getting better
Right. Right.
as
Right.
as they're exposed to more and more activity. And I was like, okay, maybe let's structure this better. Let's give them more autonomy in what they can do and stuff like that. And I've noticed significantly better outcomes because you have given them the reins. You're letting them take over their care. You're just there to facilitate and to guide them. So
Yeah.
maybe
Yeah.
this is how you segue them going to the gym,
Right. Yeah.
but
You're
they
laying the
need to
groundwork,
learn
right?
all those steps
Hmm.
first. So
Yeah. Like the one thing you said earlier was about, I forget exactly how you phrased it, but it was something along the lines of not, in this category of patients, like it's not knowing, what's causing it. It's just kind of it's kind of there. But I think you can, even though there's not like a specific like response, or we don't know, excuse me, exactly what's causing it, this is still a certain category. It still fits a certain presentation, right? So you can feel good in knowing that, okay, I've seen this presentation before. We know that over time, it typically does have a good prognosis. It just takes some time. The intervention strategy is longer. You might not get that satisfaction of being able to completely resolve someone's issue within a couple sessions. But yeah, you can feel at least somewhat confident. Okay, I've seen this presentation before. It fits. We know typically how it can respond over time, and this is what we're gonna do this to address it. And like I said, typically we can notice that improvement over time.
That is actually such a good point because before when I saw these patients, I was just like, oh, they don't fit in any
Yeah,
particular bucket for me.
yeah,
So
same.
it's just like, all right, we just toss them aside in a
Yeah,
way.
yeah.
But the fact that they do fit a presentation,
Hmm,
they
hmm.
it is consistent. There are people that fall under this umbrella,
Hmm.
means that it is a condition that we can make a change with, that we've developed more familiarity with it, and that means that we should have a better plan and approach moving forwards. So
Yeah, right.
I think that that exposure to that makes a huge difference, and it's just like, to me, it was definitely a change in my perspective and how I should be approaching these patients.
Hmm.
And once I kind of hit that switch, it made it a whole lot easier and way less frustrating. Like, there is nothing, and Mark can probably attest to this, there is nothing that would make me more mad than treating a non responsive low back pain patient
Hmm.
where I'm like, they're not responding directionally, they're not getting better with motor control or core stability. That's not even my go to, but I'll still use it to help recondition them. And I'm like, why are things not moving at a faster pace? But it's one of those things where if you track it over time, they're doing better. They're doing more. Their function's improving. Their activity tolerance is improving. And usually it takes time, but their perception of their symptoms and their pain starts to improve as well too. And
Yeah.
I think that's one of the things where like Mark and I will have these conversations, and he has always been like a bigger proponent for explaining and educating to our patients about like things that could be affecting their pain, how exactly other factors could be influencing their like their symptoms right now. And that's something I've started to adopt into my own practice as well. So speaking on that, Mark, could
Mhm.
you talk a little bit more about how you kind of start to introduce those concepts to your patients if they're struggling with like activity reconditioning and stuff like that?
The concepts like, maybe different kind of factors that could be affecting their symptoms, or
Like, yeah, like different factors that could be affecting them, and how you kind of sprinkle in
yeah,
bits
gotcha.
of education.
Yeah, I mean, part of it, especially like let's say we have someone coming in and you can tell they have a lot of other things going on in their life. Maybe they work multiple jobs, they have a lot of home stress, stuff like that. Like, I'm probably not. I don't believe I have the skill set to approach it directly head on, go into like a full blown pain education talk, things like that. But I think we're able to just slowly introduce it, right? Maybe we've been working with the person. They said they have this variable or at least consistently inconsistent response. Maybe they're improving slightly over time. And then, you're having a little bit of small talk. They're mentioning their job, home stresses, things like that. And then you just, they're introducing the topic. You could take advantage of that and you can educate them a bit. Let's say they're doing their exercise. Oh, this hurts more than last time. And then they just happen to have mentioned previously in the session that work's really stressful, life stressful in general, whatever, relationships, things like that. You just bring it in. Hey, maybe because of this new onset stress that you're having, we know there's an interaction between the body's perception of pain and just general stress, things like that. It's possible that because of this, that could be going on. Do you have any strategies that you use to manage your stress when you do have stressful times, things like that? If it goes, to be quite honest, if it goes any farther than that, I'm probably not the right person. Maybe if they if they're talking about it consistently enough, maybe you could talk about referring to, counseling or therapy, things like that. But yeah, like especially if we think that the person, they're in this activity reconditioning category and we think they fit that subcategory, or maybe there are other contributors to their pain besides just only mechanical or orthopedic factors. Yeah, I think it's worth, having that, albeit like a small conversation, just introducing it, right? As long as if you feel like it's, appropriate for that patient, because just the patient being aware and having that knowledge and having a small understanding about, oh yeah, I'm more stressed today. There's more things going on personally. Maybe this is why it hurts more. They are able to figure it out themselves. It's maybe then it kind of steers them away from, oh, there's something more wrong with my shoulder, or it's getting worse. One week they're stressed out, their shoulder hurts more. Next week they come back and they're better, right? Oh yeah, things calm down at work. I resolved that problem I was having in my relationship. It doesn't bother me as much. I think it makes sense that when I'm stressed, this hurts more. And then, yeah, then you've had that conversation, you've introduced it. Now you understand that's a factor. The patient understands that's a factor, and you can get back on track with addressing the specific symptoms that are coming in for the mechanical orthopedic component. So that's kind of how I introduce it. Like I said, I don't think at this point I have the skill set to, if someone's coming in with a real chronic pain type issue thing, I don't know if I have the skill set to have full duration sessions on just that. But I think just introducing it and slowly, and if it's appropriate, and just working it into your current exercise program is beneficial to the patient.
Yeah, for sure. And I do think that what you said about leading your patient to kind of come to that realization themselves, like, oh, I am more stressed, therefore I'm more likely to have a symptom response today.
Yeah.
And I feel better today, like I'm less stressed, or I feel good, like there's nothing going on. And my pain feels a whole lot better today. I think leading them to that realization is just so important, because then they're just like, it's not random to them anymore.
Yeah,
they have some semblance of control. And I think that is so important for these patients, because a lot of times they tend to take the perspective of like, oh, why is this happening to me all of a sudden? Why is this changing?
Yeah,
and
their only perception. Yeah, their only perception is they have pain in a certain body region. So if they don't have the knowledge to understand that other things could be affecting their pain response, they're just going to think, oh, this certain body region must be getting worse, right? My rotator cuff, it must be tearing more, or my arthritis is in my knees getting worse, right? But if you introduce that topic that we talked about when it comes to, hey, other things could affect this pain response, it can steer them away from, at least somewhat, from thinking that, something's getting worse anatomically.
Yeah, I think that at least giving them the ability to control some of the other lifestyle factors that could be affecting their pain is just really, really powerful for these patients, because like I said, it gives them some sense of control. And that falls in line with one of the strategies that I really like to use. And just like Mark said, I am not a pain specialist, or by any means of the words do I have a whole ton of experience working with the niche population of who have chronic pain. But in my experience with people who have different presentations of it, and maybe like more mild forms of chronic pain patients, I usually use pacing and goal setting with these types of patients, where it's like, okay, you did too much and it hurt. So that doesn't mean don't do it at all. It means just do less. And if you did less and you felt good and you had no issues, then maybe try doing a little more. But it's kind of learning how to calibrate how much activity you can do and understanding like, okay, this is too much, can't do that. And then this is too little and it's not giving me the desired effect that I want, or I just know that I'm capable of doing more. So gradually start to increase that is so, so important. Or learning how to break it up into different tasks or components. Maybe give yourself a time frame to work in and then force yourself to take a break. So that way, what you did yesterday doesn't end up making things a whole lot worse tomorrow. Or goal setting, understanding like, hey, maybe your goals are a little bit unrealistic at this point. You've already tried this and you've been force feeding it this entire time. Like, I know I'm this way, so it's going to be a
Mm,
really hard thing for
yeah.
me to adjust to if I ever have this. But if I have a to-do list, I'm getting the to-do list done as much of it as I can at one shot. I am not usually one to take breaks and stop and then pick it back up at another time or another date. I just want to get things done so I can move on. And I feel like that's how a lot of patients are. So being able to understand, like, hey, we did this and it's too much. Let's back it off. Maybe instead of having six things that we need to do, maybe try having two and see how you do with that. It doesn't hurt to move some of your tasks to a later date or even time, and then just seeing how your body responds to it. I think that that gives patients a lot more control over their life to where they can structure things so that they are continuing to make progress. They are understanding that how these things are affecting them, like the amount of activity that they're doing is affecting them. Do you use any other strategies like that, Mark,
Yeah,
or
I do
do
for
you?
sure. Yeah, I have a recent example where someone was coming in. They had back and leg pain in weight bearing position. Standing walk in more than 5 minutes just lit them up, right? So, I mean, I'll give the example, but the pacing and, like I said, setting objective goals. If they like this person knew after 5 minutes, if they went for more than 5 minutes, they had to sit for 20 minutes before their back or leg pain would calm down. So, let's say they want to clean the house or mow the lawn. All right, we're working below that. Maybe, and it sounds, you might have to start small with this person. Okay, you're mowing or cleaning for 3 minutes, and then I want you to sit for two. Okay, and we tested in the clinic. We tested at the eval. Walk for 3 minutes. Okay, I'm starting to feel it a little bit. Sit. And it didn't take that full 20 minutes ago. It took, like 2 minutes before it went away completely. So that we know that they're, right now, their whatever structure, their body in general, that pain response, there's a certain threshold. We know if they cross it and they do too much, it takes a much longer period of time for it to calm down compared to if they stopped before they got there, right? So our, activity to rest ratio right now is 3 minutes to 2 minutes. Over time, we can increase that. And this person found that they were able to accomplish much more uh, in a specific period of time, just in a single day, compared to when they tried to get through all of it, and then they're at that. I mean, the 5 minute to 20 minute ratio is much longer than that 3 to 2 that we talked about, right? And then we can progress that over time. So yeah, just something simple like that, like pacing, um, that slight activity modification, just so that they can do more overall. And then, like in the beginning, we said like activity reconditioning. Then we start that reconditioning phase. Okay, this has remained stable. You've been able to stick with that activity to rest ratio for a certain amount of time. Let's start to push a little bit. The symptomatic response has been somewhat consistent. We can start to work a little bit. Okay, go for 3.5 minutes, go for four, right? And then, okay, maybe try, and later down the line, okay, we get to 10 minutes in a row. They don't need a break, right? Compared to when we started, 5 minutes would put them out of commission for almost like half an hour, right? So I like that kind of approach. It certainly, when it's appropriate, it certainly works, right? And yeah, people, like I said, people want to get things done. They're used to doing things. They don't want pain to stop them. But if we know that they have that kind of symptomatic response when they pass that threshold, it's a factor that has to be addressed.
Yeah, I think one of the things that you mentioned that I really liked was the symptom stability. So sometimes these patients can have symptoms that are consistently inconsistent, right? Like they just
Yeah, yeah.
fluctuate up and down. But then the other group, which I'm glad that you brought this up, which is the people who are very stable in their symptom presentation. Now, stability doesn't always mean that it's a positive thing or a negative thing. It just
Mm,
means that's not changing.
yeah.
So usually when I think of stable symptoms, like that's someone whose low back pain has gotten better. It doesn't get a whole lot worse or anything like that. And it stays pretty good and that you can push them. But for these patients, there's also a different kind of stability, which is that their symptoms stay painful. They don't change a whole lot. They don't really get a whole lot worse, but they definitely don't get better. They're very stable with where they're at. And I think that for these patients, it's really important to test that a little bit more because their symptoms aren't highly irritable. They will return pretty quickly. It's just painful while they do it. So learning how to actually push and progress your patients accordingly to kind of test the boundaries of that stability, see if
Yeah,
how much more
exactly.
we can kind of get away with. I think that that is a very, very important thing. And it kind of gets missed because when patients are in pain, we tend to back off. We tend to not want to load. And we're already, as a profession, known for chronically
Yeah.
underloading people. So I think that's such a great thing to kind of bring up and
Yeah,
mention.
I like that you said that, like, if we know we have a stable presentation, some PTs may be likely to work in a direction where, or keep pain at a low level, or keep exercise at a level where they have no pain, right? So, and this isn't unique to simply this activity reconditioning presentation. It could be someone who, let's say they have directional preference, but initially it's painful. You keep working into it, and the pain goes away, right? There's that presentation. But when we were talking about activity reconditioning, there's a point in time, especially when we know the presentation is stable, or when it has become stable and stayed stable for a certain amount of time, we got to start to work into those symptoms. If especially if it's interfering, or the person has these symptoms when they're trying to do something that they, job related, or it's affecting their function. Yeah, we have to. I think there's certainly some merit to starting to work into it at an acceptable level to start to cause whatever adaptations may happen, so that the person has less pain or is able to perform the task better. Most in this case, at least, they're performing it better because it's less painful, right? Where some PTs may, okay, oh, does it hurt? Yeah, it hurts, and then they start to back off. Like we talked about this a while ago in an early episode about monitoring the symptomatic response, right? If you're only asking, hey, does it hurt, and they say yes, and you back off right away, what if it was like a 1 2? What if it was within an acceptable range pain wise, especially in this patient population? Yeah, we have to start to poke into it a little bit. And like you talked about, it's testing the stability. It gives us information so that we can progress or regress, just so we can adapt the plan if necessary to better serve this patient population, better address this presentation of pain.
Yeah, I'm really glad you said that because like to build off of Mark's point, yeah, what if they are at an acceptable level of pain? But even more so, what if they were going to continue to get better with more
Yeah. Yep.
repetitions?
Yep.
Like that, if you don't test that out, you don't know. Like that is just so important to at least see how it affects them. And if you're able to do that, you can also gauge how much they're able to do and then what the consequences are for the
Right.
following day.
Yep.
Maybe they have no soreness. Maybe they are completely lit up. But
Hmm.
at least this time, you've gotten a piece of information from them that you didn't have previously. And I think that
Exactly.
that's really, really important.
Yeah. Even if
Now,
they get worse, or like you said, you lit them up the next day, they're like, man, I couldn't do anything. Perfect.
yeah,
Come the next time, we know where that. Like you talked about the threshold with the patient example I have. If someone comes in and they're worse, we know where that threshold lies, right? We the information is priceless. So it just said gives us more room. It gives us more ideas to begin to better serve the patient.
yeah, it just helps you with your decision making
Yeah,
process. And
absolutely.
I think when you find out where that line is, that gives you a new goal to kind of reach.
Yeah, yeah,
And
yeah.
like simply to build off the other concept that Mark talked about, which is the adaptation to a pattern, or to a skill or an activity. As you start to do things more and more and more, normally your body a adapts to it, like the tissue adapts to the challenges, but then also like mentally you just get better at doing it. Like you are more efficient at it, you're more equipped to deal with some of the difficulties with it. So it's like maybe pushing a set hard for your patient in the beginning, they struggle with that, they don't know what it's like to push themselves, and after a couple of sessions, now they start to do more and more and more. They've realized how much further they can push themselves, and that is a skill in itself. So giving them the ability to gradually expose themselves to these different activities, or graded exposure. I think that having that is so important, because that's when they realize, like, oh, I can learn these skills. I can take the time to go through more repetitions and see how I can continue to develop here, and if this improves my pain and what exactly it does to their symptoms and stuff. I think it's just such a good way to teach them how to explore, and it shows them how their body kind of works.
Yeah, they have the knowledge. They understand when they can push it. They understand when they need to back off, right? That autonomy, that independence is, in my opinion, the ultimate goal why someone would come to seek advice or help from a physical therapist. So if they can get there, and we talked about how patients get there in other presentations, yeah, this one isn't different, because yeah, that's it. I think that's the ultimate goal from a PT standpoint, and this presentation, that goal is certainly feasible. Kane, what about, we talked about how we use exercise exposure, any other kind of interventions that you use or recommend in patients who, don't have like that quick symptomatic response?
Yeah, so most of my career, I was not the biggest proponent for warm ups for a lot of different patients. Maybe for post op patients, I would get them warming up and moving and stuff like that. I think that's awesome. But previously, I would just not use it a whole lot. But instead, I would use the extra time to just reassess my patients and make sure that I knew exactly where we were going and what to do for that session. But for the patients who are struggling with their symptom response, that's where I definitely give them more aerobic exercise. And I've noticed a huge change there, because it's like now they're starting to increase their activity, they're increasing their blood flow. And I will say this is one of the tidbits that I got from reading CPGs and stuff like that for chronic pain, where they're like, "Oh yeah, aerobic exercise helps." I'm like, "All right, fine, it's A-level evidence. We'll give it a try." And I have definitely noticed a change where people are doing these things, and I'm gradually increasing resistance and time and stuff like that, and they just feel better. They're able to tolerate these things more, and incorporating different ways of including aerobic exercise throughout their session has really, really helped, instead of just giving them I don't want to say tasks, but like sets and reps, like your standard type of like interventions. I've largely moved away from that for these types of patients, because they just don't tend to respond super well. They respond a lot better when you move them with more functional tasks in mind, or different ways. Maybe you're doing it for time, or maybe you're just do it until you get tired. And
Yeah.
that makes it so simple, but also really effective. So I think that that's one of the ways that I really have started to move towards, at least in regards to transitioning them to doing more. What about for yourself, Mark? Do you utilize anything like that in your practice to kind of bridge that gap?
Yeah, I mean, I definitely use the aerobic component. Something I like people to do at home, especially if it's something where let's say it's like a cervical case, right? And we're not getting that symptomatic response we're looking for, but I just think the general aerobic conditioning, we know it's going to have that generalized effect. I just ask them, hey, I know we've had the conversation, we've talked about the benefits of aerobic exercise. Something I think it's really simple for them to do: go up and down the stairs a couple times. Like, especially if the person, depending on their level of conditioning, depending on where they're at, that can drive their heart rate up a pretty decent amount, right? Try and do it 5 times in 2 minutes, right? That can be challenging for some people, right? Or at least it gives you that response. And when we talked about the time component, let's even say it's someone who has, let's take the other case I talked about, 5 minutes of lower back pain, right? And we talked about that 2 minute, or they have that certain threshold within 5 minutes. Okay, I want you to go up and down the stairs as many times as you can in 3 minutes, right? That's just a form of exercise. It's some kind of input to their body that can have that generalized positive effect. It's not something like, all right, you got to go to the gym and use the bike for this amount of time, or you have to go, you got to go outside, you got to run or jog, right? It can be something as simple as that. Maybe they don't have a full flight. Okay, you're going to do step ups for a minute, do as many as you can, something like that. Some form of exercise, some sort of form of aerobic input is certainly something I utilize in my practice in this patient population when it's appropriate.
All
All right,
right.
yeah. What else?
I was just gonna say we talked a whole bunch about patients who have that consistent inconsistent response.
Right.
We've talked about people who are traditionally non-responders for low back pain, for example. Now, what do you typically do for the patients who have a consistent response where it's like you do something, it produces their pain, but then it goes back down? Something I'd say along the lines of like a tendinopathy or
Right.
anything along the lines of that. What is your approach for that? Because these are similar people, I would say, that fall under the activity reconditioning or load tolerance umbrella, but
Yeah. Yeah.
they are just, it's a completely different category of patient, like
Right.
you still need to do the same things or similar things, but they just have a completely different response compared to the previous patient population we just mentioned.
Yeah. So, and this can be anything like Kane mentioned. It can be like we can use certain terms like tendinopathy or tendinosis, whatever it is, but we can also just generally apply the symptomatic response to this population. So maybe it's something where they do a certain movement and let's say at rest, they're not having symptoms. They do a certain movement with a certain amount of load or resistance, whatever it is, and they have symptoms, but it either immediately after they're back to baseline, or maybe it takes a 1, 2, 3 minutes and they're back to baseline, right? So we have that stable, consistent response. And this is adapted from a lot of the information, or the way I address this presentation is from the MDT knowledge I have. So I think, at least in this population, it's something where we know it's stable. It is responding consistently to a certain movement, and we've tested it with varying degrees of load, so that we know, okay, if we load it more, if we do more reps, if we have more resistance, their symptoms are at a higher intensity. But if we use lower load, maybe they don't have symptoms, or at least they're at a lower intensity compared to higher load. So the way I address it, and the way I found I've had success clinically, is being in that middle ground. So, let's take some common presentations, right? Rotator cuff tendonitis, where they have pain with shoulder abduction or shoulder external rotation, resisted movement, sorry. Well, maybe it's an Achilles where, resisted plantar flexion, it hurts, or lateral elbow pain, right? Resisted wrist extension or finger extension, whatever you want. We could typically, how I found I have success addressing it, is finding whatever movement or movements are the most symptomatic and having them load those movements consistently within certain parameters. And those parameters are that I want the symptoms to be produced to a certain level. I don't typically use the pain scale a lot, but in this case, I throw a number out there. I don't want it to be more than like a 5 or a 6 out of 10. Okay. While you're doing it, if it gets a little bit worse, it's okay. It shouldn't exceed that 5 or 6. Okay. If it gets better as you do it, perfect, right? But I want some kind of symptomatic response, and they should be doing it consistently either throughout the day or maybe 2 or 3 sessions throughout the day. But the main goal is getting that desired symptomatic response with the exercise, which is going to be achieved through appropriate resistance. And then the symptomatic response shouldn't last more than, at max 2 or 3 minutes afterwards. Now there's some wiggle room, right? If it's pretty reactive, maybe we're changing the dosage, maybe we have a little bit more room for the symptomatic response to last, but it should really be something where the symptoms are produced to that appropriate level to make those adaptations, and we don't want it being worse afterwards. So yeah, that's kind of the approach I take, and I think when we talk about the symptomatic response, I think it has some unique benefit over, like, oh, you have Achilles tendinopathy, right? So maybe the person comes in with that diagnosis, but we can say, hey, this is what we know. We know that we tried different movements that would typically create a quick positive symptomatic response in your pain. That didn't happen, right? We tried altering movements that you do to see if we got that symptomatic response. That didn't happen. But what we do know, and what has remained consistent, is that when we load this tissue to a certain point, you feel the symptoms that you're coming in for, but you don't feel it afterwards. So what we need to do is continue to load this, expose it to that certain amount of load, let those adaptations happen over time. And typically what we see is over time, you're able to tolerate that load better, you can do more, you function better, and you have less pain. So that's the typical approach I take. Like I said, it's a lot of the ideas are, well, from the tendon loading literature, or just, I've read some pieces on just pain during exercise generally, where the acceptable range is. And then a lot of those principles I've carried over from my MDT training as well. How do you approach these presentations, Kane? Any similarities we have? Any differences?
Yeah, I mean, I've traditionally done similar things. Like when someone has a tendinopathy, I usually will start off with lower levels of irritability, just to show them like, hey, you can do some of these things. You can start to introduce direct load to it. But I usually will just stay on the lower end of the pain scale earlier on. Like, I'll usually stick with isometrics and then see how they do with that. If there is no symptom presentation at all, that's awesome. So I usually will do that for patients in particular, for if they are more symptomatic. If they are able to do that and there's no reproduction of their symptoms, awesome. I might be able to progress them a little bit more. Maybe I have them push harder into their isometric. Maybe they can tolerate moving on to actual motion itself now. So I usually try to keep people at a lower level of pain if possible. But if their level of pain is pretty high, similar to like what Mark said, like anywhere from the 5, 6, 7 range, anywhere from there, I want to see if their pain does not go up when they are doing the exercise. Maybe it just gets like, it produces it, but it definitely should not make it a whole ton worse. And then especially what their response is like after. If their response is that it stays worse, then we might have done a little bit too much. But if it stays right around where they're at, or sometimes it even gets better with that, I think that is definitely very telling that you're on the right
100%.
Path.
Yeah,
Like,
sometimes you'll see, like you talked about getting that better response with loading. We'll typically see that. Maybe we start with a reactive type of body region, tendon, whatever it is initially, in that you do exercise, that the symptoms are produced, it doesn't stay worse, or maybe it does stay worse, but over time, as those adaptations are occurring and it's improving, you might get the response where it's like, oh, the first 3 reps I felt it, and then reps 4 through 6, the pain wasn't as bad, and then reps 7 through 10 I didn't feel it at all. So that's something we can look for as well, as the symptoms are calming down, as it's improving.
Yeah, I think that when you start to see that, it's really tough, especially I feel like for people who just aren't as comfortable or confident treating these types of pathologies, especially if you're newer. You're just like, oh no, it's painful, we got to back off, like we got to change this. And we know if we look into this, like a lot of literature states that tendons don't like either extreme. They
Hmm.
don't like to be underloaded and they don't like to be overloaded. So if someone is presenting with something like a contractile dysfunction or a tendinopathy or something along the lines of that similar presentation, it's important for us to know that we need to give the appropriate amount of loading. Like that is what's usually going to create those tissue adaptations, as well as some of the neural ones too, to help desensitize their bodies to their symptoms and then gradually see that we're going to start to make improvements.
Yeah.
The reason why I bring that up is because if you are too gun shy when it comes to some of these things, then you're probably just missing the boat on this, where you aren't giving them the appropriate loading for an appropriate duration of time.
Yeah.
Sometimes you can get away with like you see an improvement in their symptoms after a couple of reps and
Hmm.
awesome, you get that confirmation. But for a lot of these patients, you don't always get that. You
Yeah.
are
Yeah. I mean,
probably just
mm,
you're gonna have them go through the movement. They're gonna be like that for a few weeks before you start to see any improvement, but
yeah,
you're going to have that gradual progression.
exactly. And typically, this presentation is chronic. So I find at least like these people have had this thing going on for like at the very minimum, at least the people who at the time they're seeking care, let's say the minimum like 6 months. Usually, at least in my experience, these people are like, oh, it's it's been 1-2 years, something like that. They've had it going on for a while. Maybe they may or may not have had previous treatments. They're willing to do things, right? So I don't think we gotta back off. They've had this pain for a while. It's typically not changing at this point. It's leveled out. It stayed the same. Oh, initially when I first had it, it wasn't bad, and it got and then it got worse, but now it's just been at the same level. Okay, they're telling you it's stable. It's been stable. They know when it hurts. They know when it doesn't hurt. Yeah, you can start to push things a little bit. Like you said, the underloading is a huge issue. I can think of a couple cases offhand, but I can think of one where this person they were used to training at a certain level. It was a like patellar tendonitis type thing, whatever. Um, yeah, they're used to training at a certain level. They had a huge drop off in training volume and intensity. They maybe 2 months later started to get back into stuff. They didn't start too fast, but anyway, it was a huge drop, a big change in the load that tendon was used to handling. They started to get back into it, and it was a little, it was trying to figure things out. So their instinct was to stop. Every time they kept trying to train again, it would hurt. So they sought treatment. They went to PT, and the clinic they were going to was okay. Nothing should hurt, shouldn't do pain. They'll do modalities. Or what do you think happened? There was no adaptation occurring. The tendon never got used to load. Every time she tried to go back to doing deep squatting is when it hurt. Every time she went to go back to doing it, it hurt again. So she would stop. Right? Um, Listen, girl, you got to start pushing it. It's been like this for 2 years. You know how it responds. You know how it's been reacting. It needs time and it needs the input and exposure to adapt, right? So yeah, I like when you talk about the underloading and the overloading principles, like tendons, the huge change. Um, yeah, they typically don't respond well to those changes. So with the gradual exposure, the gradual um, introduction of load, and we're gauging the symptomatic response the whole time.
So I think I do think it's important to talk about like the loading aspect of it. And we talked about loading strategies as well too, in the last episode. But I think that it's important here to understand that we can change a couple of variables here, right? Like how much weight are we using for an exercise? How much volume are we giving them as well too? And then also different positions, like are we stressing it in a more lengthened position? Tissue is definitely going to have a much more reactive response if we're working in lengthened positions or if we're
Yeah.
utilizing more eccentrics and stuff like that.
Yeah,
These are
contraction type
all
too. Like you said, isometric, something maybe you'll start with, and then you can go to your um, isotonic, and then yeah, I mean you got room for plyometrics as well when you're getting down the line.
For sure, for sure. All these are different variables to consider in your exercise prescription. They are all, I like to call them levers that you can push and pull
Mhm.
to make sure that you are getting the desired result out of your patient and seeing how their symptom presentation changes. If it changes for the better, that's awesome. That means that you made the right decision. But if things are getting worse, know that you don't have to abandon everything that you did. You can always just change a couple of those variables to maybe make it a little bit more suitable for your patient. And I think that that's something that kind of gets missed a lot. And I don't know why, but a lot of times when I see people loading stuff for this, it's like there's only one way to do it, and then after that, if it doesn't work, they're just like, oh, no, 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 let's just do something else, and they just completely abandon whatever idea that they had, even if it was a good one. I'm
Yeah,
just like,
yeah.
whoa, whoa, whoa. Just because it didn't work doesn't mean you have to scrap the entirety
Hmm.
of it.
Right.
Maybe just go and revise and change one or two things and see how that affects your patients. I think that
Yeah.
is like a huge thing. And like, what do you typically do? Do you often look to change your exercises like that? Like just making minor adjustments to see if you get a better response, or have you noticed that one variable makes a is more suitable for patients like these, like whether it be changing volume or changing your loading for them?
Yeah, I mean, the first variable I tend to change is the amount of external resistance that's provided. That seems to be a big driver of the symptomatic response. So especially initially, right? Like I can think, um, let's just take lateral elbow pain. Like we'll call it a wrist extension. Yeah, they have pain with wrist extension. Grab a couple dumbbells and we're testing it out, right? That's usually the first variable that I'm tweaking, and so that I can get the desired symptomatic response. From there, if they can tolerate, I guess I should put it this way. I'm looking for them. I know you said you usually start a little bit lighter. I said as long as it's stable, I'm looking to get in that like mid-range pain level. So if they can tolerate a isotonic contraction, like under load, then I'm starting there, right? I typically don't test isometrics initially unless it's something where they really are having issues working into it, right? And then maybe we can start to look at the joint position, right? So if it's really tough for them, maybe I'm doing I'm changing the joint angle to do isometrics in a less challenging or less stressful position for that tissue, that tendon, muscle, whatever it may be. So yeah, external resistance, contraction type, joint angle. That's usually where I start. And then once you get the ball rolling, once you're on that initial plan, then things just kind of come along, right? If it's depending on the person's goal, if it's like a lower body, um, let's call it tendinopathy, whatever, pain with resistance type issue they're coming in for, and they're wanting to get back to a certain sport, they need to be able to hop, jump over things, whatever it is. Yeah, we're getting there. We're getting there down the line. But usually later down the line, I don't find pain is an issue. We can maybe segue this into like how we start to progress, like the reps and stuff like that. Like I expect the pain to be an issue, or you get that pain response maybe for the first 4, 5, 6 weeks, and then we should begin to see those adaptations occurring to the point where it's not as high, or they can tolerate like a good amount of load or demand through that structure that they can start to progress, right? And let's just take a lower extremity tendinopathy, for example. Maybe it's not like once we're getting to plyometrics, once they're jumping, once they're loading pretty good, we're just looking to make that tendon more, let's just say, robust and resilient, right? I'm not looking like, okay, every time you jump, I want you to be at a 5 or 6 out of 10, right? That's usually early on when we haven't had sufficient load, sufficient input to drive that adaptation to reduce pain. So yeah, typically what I look to change, especially earlier on, is that the amount of resistance. If we need to scale back, yeah, we can look at the contraction type. Maybe we go from like an isotonic to an isometric, and then if I really need to fine tune things, we can look at joint angle. Yeah. Do you?
Man,
Yeah. What do you got? Let's hear it, man.
you said a whole lot there, man. That's
That's
this is
listen,
the
man. That's my little formula. All right.
I like it. I like it. All right. So the one thing I do want to touch on
Yeah.
is the plyometrics portion. So I
Right.
will say I do not introduce plyometrics until their pain has been well controlled
Yes. Yeah. That's
because
essentially what I was getting at. Yeah. I'm not, like I said, I'm not. If someone's coming in and they're jumping and stuff like, oh, that hurts. That hurts. Even if it's like that produce no worse response, like I don't know, maybe I do it, but I think if they're at that level, if they have that high pain with that amount of demanding loading, like I'm not exactly comfortable with that.
yeah, I don't like it because
Yeah,
you
yeah,
just can't control how much
yeah,
force you're
yeah.
putting
Good
on
point.
it.
Good point. Good point.
And also the amount of time that you're spending in a like with plyometrics is just so low. Like you're not really loading the tissue with a significant amount of time. You're loading it with a
Yeah,
sheer
you don't have.
magnitude of
Yeah,
force.
you don't have that that slow contraction with heavy external resistance to build that stiffness. Right. Yeah.
Yeah, so that's one of the things I will for sure say is a pretty steadfast rule for me. Maybe you can introduce some, but it's relatively light. But for the most part, it's like, have we gotten things to calm down? How stable is it now? And is it showing continual signs of progression? And I think that is like one of the more important factors that I use when I'm considering moving someone towards or advancing them to plyometrics. So definitely something worth considering, especially for like your jumping athletes and stuff like that. The other things I wanted to talk about that Mark mentioned, I thought were really good, which were so I use isometrics for sure when we just like we stated previously, but I will add in the caveat of my isometrics may be a little bit different than
Hmm.
how some other people do it, where there are times where I will just give them manual resistance, especially if it's like a
Sure.
smaller body part,
Hmm.
if it's their shoulder or their elbow,
Pinky
something like
toe.
that.
Yeah.
Oh yeah, for sure, for sure. So I am loading these guys. I'm pushing pretty hard to see when we can trigger some of their symptoms. And if I'm pushing like as hard as I can and they can tolerate that and they're holding it and not having any issues, like they're going. It's not
Right.
like we're
Right.
just
Right.
lightly pushing in. Like we are still adequately challenging that muscle. And then the same thing goes for if I can do that and they have no problems, then why are we still doing it? Like we should probably move on at that point. So I think that just because an isometric is termed as an easy exercise, it does not necessarily mean that it needs to be easy. Like you can really, really push the boundaries on these things. And what Mark said about changing joint angles, I think is super, super important too, because it's one of the factors that I use to change the exercise. So one of the best examples I can think of is if I'm doing a shoulder external resistance isometric, right? And even having them at neutral causes them to have a lot of their symptoms. So you can test this out, but if you move them into more external resistance and you shorten the tissue more, if I were a betting man, I would be very inclined to say that their pain is probably going to go up. So if you change that joint angle to give them a little bit more IR and give them a little bit more room for the muscle to work with in the mid-range position, if I were once again a betting man, I would say that their pain is more likely to go down. And you can probably go through a couple sets like that and then retest it with more ER, and you'll probably see that their symptoms are better. So
Right.
changing their joint angle, I do think is very, very important. It's a key thing that you can certainly do and consider, especially for shoulder. The one thing I really do want to mention is for a lot of these conditions, especially for Achilles, your ankle can only do so many motions.
Hmm.
I'm not keeping someone on my caseload for a prolonged period of time. I'm not scheduling them out 2, 3 times a week.
Yeah.
I'm not even scheduling them out once a week most of the times for something like this.
Yeah.
It's usually like once a week for the first like 2-3 weeks. After that, I am very
Yeah.
quickly moving
And
them off.
and do you have a goal those first couple weeks? Like I know
Yeah.
for me, I'm
Well,
just like to me it's testing the stability, knowing what we got.
yeah, so definitely checking out their symptom presentation, right? Like if it responds favorably, we can move, we can
Right,
progress, we
right,
can move
right.
along fast. The second thing that I'm looking for is educating my patient, letting them know, hey, this is what you should be feeling. Here's how you should know to progress, and then here are the signs that you need to know to back off. Once you have taught your patient this, they can do this themselves at home, especially for Achilles. Like it is so easy to go through a calf raise progression. Like it's like you can write this out for them. So you start off on the ground with both feet, and then after that you can try going onto a step and then increasing some of that load or some of that range of motion. Awesome, they can do this, no problem. Now you go back to the floor. You can try 2 up, 1 down. Then you go back to the step, 2 up, 1 down. You go back to the floor, single leg. You go to the step, single leg. Done. That is your
Yeah.
calf raise progression. You can add an emphasis on eccentrics if you want to. That's totally fine. But all these are just the ways that you increase the difficulty or complexity. And you write that down for your patient, they're gonna know, okay, well, I did this and I have no issues. I can jump on to the next step. And the reason why I say this is because I had a patient who she had a really high copay. I saw her for 2 visits in the beginning, educated her, got her symptoms down to respond better, but she was still symptomatic, and that's fine. And I was like, okay, so you're still getting better. You're responding exactly how I expected you to. Let's reconvene in a month. She comes back in a month and she's like, things are getting better. They're way better. They're not gone, but they're still like they have been significantly improved from where she first started. I give her a call in another month. And she's like, all of it's gone. Thanks for checking in. I really appreciate it. She had, like I said, she had a high copay, and she was really, really grateful for the fact that I didn't just bring her in to do the same exact exercises
Exactly.
again and again and again.
Yeah, this
And that is, it's
Go
just
ahead.
so important for
Yeah.
your patients to
It's
have
a-
that autonomy.
it's a really important point too. Like you said, you can only if we know the presentation is stable and we know how it responds to load. There's only we don't need to be doing a bunch of different exercises, right? The person needs to understand the progression. They need to understand how they can alter or modify movements so that they can increase or decrease the load on that structure. And then they need to understand what the expectations look like. What's the timeline? We already said, like we talked about this presentation, we've ruled out the quick responders. It's most likely not happening here. It's going to take some time. And as long as the person knows that, as long as the expectation is set, they understand the game plan, yeah, that can dictate, like I said, the visit frequency, or at least you set the expectation so they know if they come back 2 weeks later and they're like, hey, I'm doing the exercise and yeah, my symptoms are about the same. Perfect. That's how this presentation should be. I mean, if it got better, even better, cool, fine. But if they're the same and it takes, 5, 6, 7, 8 weeks before you start noticing change and their functions improving, you can, like I said, we were talking about at the beginning of the episode, like Kane mentioned this him personally, but I was the same way. It's hard to be comfortable knowing that something's not going to change quickly, but you can find comfort and security in knowing that, okay, we've seen this presentation. We know how we expect how it's going to respond. As long as the patient understands that it's going to take some time, but it typically responds favorably, then they won't be upset that 3 or 4 weeks later they're about the same.
Yeah, and I think that one of the things that, and I'm sure that we could have another episode on this, but it is something that has stayed in my head for a while, is that in PT, like you are seeing your patients all the time, right? So it's just one of those things where, like, if they aren't getting better, sometimes you just feel this like sense of dread or
I was going to say
anxiety.
dread too. Yeah, man. We were
They're
thinking
not getting better. Why aren't they getting better? Why do I
Yeah.
suck? And it's just sometimes you just want that confirmation that makes you feel better, that where you're like, oh, I'm on the right track.
Yeah.
And
Yeah.
that's why Mark and I talk so heavily about test retests, because you don't always get that in PT. And if you do get that, don't let it go. You need that. You don't always
Mm-hmm.
get confirmation. So when you do, you need to make sure you have that. Now, with that being said, for conditions like these, this entire episode is pretty much for non-responders or slower responders for the most
Right.
part. But knowing your healing timeframes, knowing what your expectations should be like for a prognosis like this is so important for you to develop your confidence in how your plan of care is going, knowing when you should have to pivot or knowing when you need to stay the course. That these are all really, really important things to consider for patients like these, because you could just be jumping the gun. Just like I said, maybe you're moving too fast. Maybe you are trying to get them better too quickly, and it just doesn't match with expectations. Same way that we said that patients should have appropriate goals for their activities, PTs should also have appropriate goals for where their patients need to be. Now, with that being said, we talked about different guidelines that we could use. So Mark uses the pain scale of producing but not making it worse, and seeing if it comes back down to baseline for his exercises. And I think that that is very, very appropriate. Now, with the conversation that we just had about expectations, different time frames, Mark, what do you usually expect when it comes to the prognosis of these patients? How quickly are you expecting to get them better or seeing a change in their symptoms?
Yeah. The information that I was provided in courses and from papers is maybe that 6 to 12 week range. Now, maybe this was really measuring a more specific population than what we're describing here, because the papers I'm referring to are based on tendinopathy, tendinosis. Like I said, maybe it's a way more specific population than people who just have pain when they perform a resistant movement, and it doesn't stay worse afterwards. Or I said, their response can sometimes be invariable, right? They don't fit a specific or the different presentations that we talked about. But like I find typically the people can respond more quickly than that like 6 to 12 week mark. Usually, like if we're loading for like 3-4 weeks, like I feel like they should notice something different. Like okay, as long as they've been doing it consistently and they're within those guidelines, they should be like, oh yeah, and I'm doing this exercise, and actually I notice, even if let's say it's something small, like oh, I notice I can carry like 2 grocery bags and it doesn't hurt as bad as it did a couple weeks ago. Okay, something's happening there, and it's consistently better to them, right? Maybe I haven't seen them in 2 weeks. I went shopping 3 times and they carry the bag each time, right? 3 different occasions, 3 different days where they've noticed something different. But I still do make sure to tell them timeline wise that it's usually slower, but prognostically it's typically positive and typically does respond, right? Do you explain any differently? Like I said, I like from a research standpoint, it seems to draw it out a little bit longer, but I find it usually responds quicker. At least like
Yeah,
some small response early on.
yeah, it really depends on their symptom presentation, because I've seen some tendinopathies, and I'll usually say the same exact thing that Mark just said for like the prognosis. Like, hey, this is just what has been stated to be the normal time frame for when we could expect changes, right? And I think a lot of the timeframes that we're given are usually on the more conservative end, which is totally fine. It's better to what do you call it? Undersell and over deliver.
Right.
So I think that's totally, totally okay. And especially the patients who are more symptomatic and they're slower to respond. Yeah, they'll fit more in line with that healing time frame. But if a patient has like low irritability, they're responding well, we can see quantifiable or quality changes in their symptoms, within that session, within a set or two sets, that's telling me that they're going to respond just fine. Like we can definitely progress them pretty quickly to make sure that they are loaded appropriately. And those patients, I will usually say, hey, this is the time frame that research usually says for this condition, but you're responding really well. It would be totally normal if you responded faster than that time frame, and that you continue progressing without needing all these visits, right? So I think that prepping them for that kind of gives them like some insight, and you're like, oh, so normally this is how people respond. You're responding better. So it's totally fine for you to continue moving forward at a faster rate. Like, and then the same thing goes for the people who are struggling. Like, hey, like if I'm testing, retesting, that's fine. If there's no change, I don't necessarily expect there to be a change, but I want to capture that.
Yeah. So like
right?
test retest still has value in this patient population.
Oh, for sure,
Yeah.
for sure. Like if I do an isometric on a patient and it's like the first eval, first follow up, or anything like that, you can guarantee that I am retesting it to make sure that if there's a change, I know about it.
And we're taking advantage of it. Yeah, using that information. All right. Anything else you want to add to today's episode, Kane?
No, I think we talked about a whole lot today. A lot of interesting different conditions and diagnoses and how to best approach them. I thought that we went pretty in depth about what our approach is like, and kind of like our practice philosophy on why exactly we're doing this. So I thought that we ended up covering a whole lot today. And they're really common presentations that people struggle with too.
Yeah, it's a common presentation like we discussed. There needs to be some degree of load. There needs to be some kind of input so that these tissues can adapt, or at least if the person just needs exposure to the activity so they have less symptoms when they're performing it. We talked about how we utilize different tools, whether it's different pain parameters during loading, whether it's things like great exposure or aerobic exercise. And we talked about, like I said, sometimes the symptom presentation is variable. It's consistently inconsistent. Sometimes it's consistent. And depending on the presentation, the interventions can change, and as well as the dosage. All right. Well, that concludes today's episode of the PT Good podcast. Remember to leave us a like, subscribe to us on whichever platform you're listening to us on. Follow us on Twitter at PT Good Podcast. We thank everyone for listening. We hope you enjoyed, and we will see you on the next episode.
Miss you, love you, bye.